Good evening all and welcome back to Ophthalmology Classroom. This is the 13th edition of Ophthalmology Classroom, and today we are privileged to have with us the Medical College, the Government Medical College from Thrissur, with Professor Sudha and Professor Mallika as our internal examiners. Dr. Faiza Ibrahim is going to present a case of Panuveitis, and with us today will be Professor Vinod Kumar Agarwal from RP Center, New Delhi. Welcome, Dr. Vinod.
Thank you.
So without any other further ado, let's start the case presentation. Dr. Faiza, you can share your screen.
My slides visible?
Yes. You are visible and audible. You can continue.
Good evening, everybody. Good evening, sirs, madams. I'm Faiza Ibrahim, junior resident of Thrissur Medical College. I'm presenting the case of a 44-year-old male who was a painter hailing from Thrissur. He's presenting complaints, defective vision of both eyes since the past 2 months. History of present illness. He gives a history of fall of white cement to his left eye 2 months back, and for which he had consulted a nearby hospital, and he was given eye drops for the redness and foreign body sensation he had. And it was at this time he had instantly noticed that he had defective vision of his left eye. And 2 weeks later, he happened to notice an insidious onset of gradually progressing painless defective vision of his right eye also. He gives no history of any redness, photophobia, no history of flashes of light or floaters, no history of headache, nausea and vomiting, no history of any chronic cough, hemoptysis or even rise of temperature. He gives no history of any skin lesions, hypopigmented patches, genital lesions, or any recurrent or painful or painless mouth ulcers. There's no history of contact with pets, no history of joint pain, no history of loss of appetite or loss of weight. There's no history of tinnitus or any hearing deficit. He gives no history of any recent or past intraocular surgery. Coming to past history, he gives a history of trauma to his left eye 2 years back following a fall, and he had developed redness of his left eye, and he had consulted a nearby hospital. No other details of this event is available. No history. He gives no history of any recurrent episodes of redness with photophobia in the past in both eyes. He is not a diabetic. He has no hypertension or bronchial asthma. He's not having any history of contact with any tuberculosis patient. Personal history, his sleep is normal, appetite normal, bowel and bladder habits are unaltered. He has no addictions. Family history, he gives no history of any chronic ocular diseases in his family. Socioeconomic status, he belongs to a below poverty line status. General examination, he was FF right.
Dr. Faiza, at this moment, with this history, what exactly is your, what all have you considered?
And with this, his history was a painless progressive loss of vision of his right eye, which was preceded by the defective vision of his left eye, which he had incidentally noticed. So we don't know the onset of his left eye defective vision. And he says this defective vision has happened since the past 2 months. 2 months history he's giving, and he's not having any comorbidities, and he's not having any similar episodes in the past of any redness or photophobia.
So he was working till those 2 months. He was doing his job.
Yes, he was doing his job. He was fine till the 2 months, and he happened to notice his defective vision only when he had an episode of redness following fall of white cement in his left eye.
So it's a subacute kind of a loss of vision, which is not very painful. So what made you consider inflammation, or what are these points which you are considering now?
Since it is a insidious onset of painless loss of vision involving both the eyes with just a week's interval, we have to consider certain differential diagnosis like some retinal detachment. Also, it can be considering inflammation. It can be a posterior uveitis or a panuveitis. We have to consider, like we have to consider the retinal detachment part, and also cataract cannot be considered. It is a gradual, painless, progressive defective vision because it cannot progress within weeks. And also we have to consider optic nerve diseases cases like ischemic optic neuropathy, in which one eye can be involved and the other eye can be involved within weeks. But the age is also unlikely, and he's not having any comorbidities. So mostly it's an intraocular inflammation, and
so the subacute kind of intraocular inflammation, which is not noticed by the patient, but he was able to work till then. So we assume that till then his working pattern, he could manage with it.
Yes.
Any comments, sir?
I think that is one important message or clinical situation arises in this particular patient is that many a times patients with unilateral loss of vision, they wouldn't realize at all until and unless they come across an event such as this in this particular patient. So many a times the patient would notice the loss of vision only when they come across with trauma. Now this trauma may or may not be significant. So what we need to see is whether this loss of vision is due to this episode of trauma or it had been pre-existing. Okay, so that is something, again, because patient never noticed, you will not be able to decipher just by the history. Examination becomes very important in this patient. And again, history, I always feel in ophthalmology is I'll not say not useful, I'll say not as useful as is there in certain, for example, streams like medicine, where history is very important, because most of the findings we can see, and that will give us a clue to our diagnosis. So,
but I would like to ask Faiza. There was no redness, there was no pain, there were no floaters, and how did you zero in on inflammation based on this history? Would it have been a corneal condition like a corneal dystrophy which worsened, or a cataract which was like development or something which progressed? Why did you zero in on to inflammation without pain, redness, watering, photophobia, floaters, any of these symptoms?
It is just because he found that there was a significant loss of defective vision of his right eye, similar to his left eye, which he had instantly noticed. That is within the weeks. So cataract and all, it is unlikely in this age group, 44 years. And if it is so, it is a cataract that it is unlikely to be progressed within weeks. And
can it be bilateral corneal edema?
Corneal, but he has no pain. He's not complaining of any colored halos.
Okay, so whenever you have a baseline history like this, which is not suggestive of anything, don't jump to your diagnosis. You just jump because you have examined, and we all know that you have examined and you're putting it here. So don't jump to your diagnosis. You think from anterior to posterior. What all are the possibilities, and then tell accordingly. From anterior to posterior, yes, there is no colored halos. I agree, but you can have corneal edema without that also. You can have high drops. It would have been a keratoconus without with high drops developing now. So there are a lot of possibilities. It could be a bilateral CSR. Okay, because he had some steroid inhalation or inflammation, whatever. It could be a bilateral CSR. So don't jump into a definitive diagnosis like, or a etiological diagnosis like inflammation without redness, pain, watering, photophobia, floaters, anything. If you had any of those, if you had a rheumatological disease at hand, if you had some tuberculosis history, strong history, then you could have been a little more, okay, this is looks like inflammation, right? Okay, let's move on. Vinod, anything to add? Mallika ma'am or Sudha madam, anything to add?
I agree with you. We went too fast into the inflammation part, but she's right about this, that it's a little younger patient when you can't consider cataract as such, and it is a little subacute progression. One eye noticed and the other eye also gradually lost vision within 2 months.
One more thing I want to ask Faiz is, how much was the degree of decrease of vision from history? That you did not say. We have the visual acuity coming in, but from history, what was it that he could see? What was it that he could not see?
He said he could not see the faces. He said that it was decreased to such an extent that he was not able to see people's face.
Okay. I could not identify or could not see.
Could not see clearly.
He could not obviously read then.
No, sir.
Okay, fine. So based on history, these are the things you will ask, whether the patient is able to read, identify faces. When you say identify faces, always tell about how much distance, like from 6 feet or 2 feet or 1 meter or whatever distance. Probably next thing that you will ask is, can he see the bus boards on the bus, or see hoardings or large billboards on the roads, etc. So these are some things which can give you a clue as to how much the vision has dropped. So the right eye as well as left eye, you are telling that he was not able to identify faces.
Yeah.
All right. At a distance of about. Okay. So that's how you talk about history of decrease of vision. All right. Okay. Let's move on. Can you share the screen once again?
Yes, sir. Moving on to general examination, he was afebrile, there was no pallor, icterus cyanosis clubbing, generalized lymphadenopathy of pedal edema. His vitals were stable. Skin showed no evidence of any skin lesions or vitiligo. Hair showed no evidence of alopecia foliosis. There was no evidence of pitching of nails. Systemic examination. Central nervous system, he was conscious and oriented. The examination of all the cranial nerves were within normal limits. Examination of motor system and sensory system were also within normal limits. There was no evidence of any cerebellar signs or no evidence of any signs of meningeal irritation. Cardiovascular system was within normal limits. Gastrointestinal system examination, he had a poor oral hygiene with no evidence of any mouth abscess, and para-abdomen was soft and non-tender. Respiratory system examination was also within normal limits. Musculoskeletal system examination, there was no evidence of any joint swelling or deformity. He had a normal gait. Moving on to ocular examination. The best corrected visual acuity of his right and left eye both were 1 meter counting finger. Near vision and color vision could not be assessed. Retinoscopy could not be done as it was a plain red view. Head posture was normal. He was orthophoric. His ocular movements, ductions, versions, and inversions were fluid in both eyes. Examination of right and left eye. Orbital margins were intact. Eyebrows, no medullossus, scoliosis. Eyelids and eyelashes. There was no evidence of any vesicles or lashes. No evidence of blepharitis, nephritis. No evidence of foliosis. Conjunctiva showed a mild circumcorneal condition with no evidence of follicles or papular conjunctiva. There was no evidence of any conjunctival nodules. Sclera, no evidence of scleral thinning, discoloration, or dilated episcleral vessels and scleral nodules. Cornea was normal in size, shape, and transparency. Corneal sensations were normal in all 4 quadrants. Epithelium and stroma was normal. Endothelium showed a few pigmented keratic precipitates inferiorly. Anterior chamber was normal and regular in depth. Peripheral anterior chamber thickness was equal to half corneal thickness, corresponding to Van Harris gradient. There was 1 plus cells and 1 plus flare. 1 plus flare. There was no evidence of any hypopyon or hypo. Iris pattern was lost diffusely. Yes, ma'am. Yes, sir.
So at this moment, I would like you to elaborate more on KPs, keratic precipitates. What kind of KPs were they? They were small in size and distribution.
On examining the corneal endothelium, it showed evidence of small pigmented around lesions which is present on the corneal endothelium inferiorly, which was scattered inferiorly, and it is suggestive of few pigmented keratic precipitates, suggestive of old keratic precipitates. Small in size.
So in both eyes, you had old keratic precipitates.
Yes.
So even in the left eye, which was more recent to start with, the decrease of vision was more recent to start with, you have old crenated, pigmented, fine keratic precipitates, is it?
Yes, there were very few in number, just 2 or 3. That's
actually this patient was partially treated from outside. He was
Sure.
on steroid. That was the problem.
Sure. Okay. So can you tell me what is the significance of Vinod's question? Like how would you what does he want to know when he asks, okay, what is the type of keratic precipitates? What is the distribution of keratic precipitates?
Keratic precipitates, there are fresh and old keratic precipitates. Fresh keratic precipitates are white, hydrated, three-dimensional, and mostly all the keratic precipitates are found in the arch triangle, that is with the base down and apex towards the pupil. And the all old keratic precipitates are round with crenated margins, and they are pigmented. So it signifies a fresh keratic precipitate. It signifies an acute attack, and old signifies a chronic anterior uveitis. And the size of the keratic precipitates, it can be small, medium, or large sized. Small sized are mostly fine KPs, keratic precipitates, and medium to large sized. KPs are found in mutton fat KPs, which have a typical appearance. That is, they are large in size, and they are yellow greasy appearance, which is mostly found in granulomatous uveitis. So these fine keratic precipitates are found mostly in non-granulomatous uveitis, anterior uveitis.
Okay, that's very important. So whenever you mention keratic precipitates, one is that you distinguish which kind of size of the KPs. That is a very crucial clue towards differentiating granulomatous versus non-granulomatous uveitis. And secondly, if you're talking about non-granulomatous KPs, that is small KPs, then distribution is very, very important. Certain cases like heterochromic iridocyclitis, sometimes even herpes, you will find that they are distributed throughout the posterior surface of the cornea. So that will give you a very important clue towards the diagnosis. So these are 2-3 things you must see about all the KPs in all inflammatory cases. And plus, whenever I think you'll be coming to that iris, no? So findings
Yes.
of iris, yeah.
Yes.
Yeah, so if it is, if there are fine keratic precipitates, more chances of it being an acute uveitis than a mutton fat, which is usually chronic. From your history and from your initial thought process, it looked as though it is a more chronic variety. So you would have thought, because there was absolutely no redness or anything like that. Okay. Whereas usually the fine keratic precipitates will be more usually seen with more acute anterior uveitis, which will have redness, pain, watering, photophobia. Okay, so there is a little bit of atypicality in that. Okay, fine.
Moving on to examination of iris. Iris pattern was diffusely lost. There was no evidence of any iris atrophic patches, iris nodules, or neovascularization of iris. Pupil showed a 360-degree posterior synecdoche was present, suggestive of seclusion pupil. It was 3 millimeter round, and direct and consensual reflexes were non-reactive. Lens showed a posterior subcapsular cataract with pigments present over the anterior lens capsule. The anterior vitreous face could not be seen. Distant direct ophthalmoscopy showed a faint red glow with central lenticular opacity. Fundus examination, the disc and macula was examined using 90 lens. Media was very hazy due to lenticular opacity and properly vitritis. Disc and vessels were seen. Disc margins were well defined. Disc was an average size disc with vertical size 1.82 and horizontal size 1.69 with a correction factor of 1.3. Cup disc ratio was 0.3. Neuroretinal rim was pink. There was no evidence of any disc edema, neovascularization of the disc, hemorrhages or exudates over the disc or in the peripapillary region. The macular details could not be made out. Examination of the periphery with indirect ophthalmoscopy could not be done because the pupil was non-dilated. This is a fundus picture of the right eye and left eye posterior disc. The applanation.
Faiza,
Yes,
sorry to interrupt you. Now, once you say the findings using 90D lens, macula could not be visualized. So I'm not going to the finding as such, but remember, if you are not able to see with the 90D, please make a effort to to see macula even with the IO. IO, indirect ophthalmoscope, is just not meant for the periphery of the retina. Okay, so whenever the media is hazy, even if pupil is small, you go to small pupil option, you will be able to make out the details of the even macula better with indirect ophthalmoscopy. So we'll come to findings later once you finish.
Application tonometry of both the eyes showed a value of 4 millimeters of mercury. Gonioscopy showed a grade 3 open angles in the superior, nasal, and temporal quadrants, and grade 4 open angles in the inferior quadrant, according to modified Sheffield screening. There was evidence of hyperpigmented capillary meshwork. There was no evidence of any peripheral anterior synechial and neovascularization of angle. Examination of lacrimal apparatus of right eye. There was no evidence of swelling or tenderness of the lacrimal sac or gland regions. The regurgitation test was negative. Examination of dry eye of both eyes. Schwimmer's test was 20 millimeters of mercury. Teophyllin breakup time 15 seconds, and teophyllin height was 1 millimeter. No suggestive of no dry eye. So since the fundus was not periphery of the fundus could not be.
So I think we can. Before we go further, just a second.
Yes, with this examination, what would be your provisional diagnosis with this history and examination?
With this history and with this examination, since the patient is having mild circumcorneal condition with few pigmented KPs inferiorly, and 1+ cells and flare in the anterior chamber, and a 360-degree posterior synechial, and a posterior subcapsular cataract and pigments over the lens capsule. I would suggest it as a chronic anterior uveitis.
Bilateral.
Yes,
bilateral
chronic anterior uveitis. And since the fundus examination, only the posterior pole could be seen, and there was no, the disc was normal, macular and the peripheral fundus radials could not be assessed. So,
but how do you explain the severe loss of vision? 1 meter loss of bilateral, you are saying 1 meter. So how do you explain that?
Bilateral severe loss of vision, it could be because of the intermediate uveitis, that is a severe vitritis which is present, or it could be posterior involvement of the posterior choroid. So for that, we have to do further investigation, since the fundus examination could not be seen with indirect ophthalmoscopy. So the severe loss of vision could be either due to the severe vitritis due to intermediate uveitis, or due to the posterior choroid or retinal involvement. Posterior uveitis.
Explained by the cataract which you have mentioned, posterior subcapsular cataract.
Yes, madam. Posterior subcapsular cataract.
Significant enough.
Yes.
Do you think it was significant?
But with the history, he gives a sudden, in an insidious onset. Within 2 weeks, he's recognized.
Okay, but do you think the media was suggestive? The media laid suggestive of such significant vision loss due to cataract.
It was hazy enough, but not more because of the cataract. It is because of the intraocular inflammation which was making the media more hazy.
I think we were able to take fundus photograph itself.
Yes.
Which may suggest the cataract part is not so significant. What do you say, sir?
Actually, that media clarity will account for about 6/60 vision. 6/60, 6/36.
But the vision is lower than
1/60. Right. It's about 1/60.
Hmm.
So, Faiza, you diagnosed that it is your provisional diagnosis chronic anterior uveitis, bilateral. Is that right?
Yes.
But then you also told us that there is a lot of vitritis and vitreous haze. Will that have a problem in your diagnosis?
Considering the considering the vitritis part, it can be intermediate uveitis with spillover anterior uveitis, but the anterior iris and the cornea, as well as the 360-degree posterior synechias. This acute pupil, it suggests a chronic picture. So
I don't think she saw the vitreous cells. She was just saying probable vitritis. She was not able to see the vitreous. Were you? Were you able to see the vitreous?
No, madam. Only the lenticular opacity was appreciated.
In the
vitreous
slit
phase
lamp.
could not be.
In the slit lamp.
Yes.
But in the indirect ophthalmoscopy, you can see the vitreous exudates, right?
Yes.
So did you see the vitritis during your indirect ophthalmoscopy?
In the indirect ophthalmoscopy was the media was hazy.
But you said that the cataract was not severe enough to cause the media haze. That also you said.
Yes, the vitritis, the peripheral lesions could not be assessed, like snow walls or snow banking. The anterior vitreous phase could not be assessed with slit lamp and night.
Paisa, you said the IOP is only 4. What is the reason for the low IOP in uveitis?
Initially, in uveitis, the IOP can be low because of the ciliary body inflammation which takes place. Then gradually, in the IOP can build up, and then in the later phases of uveitis, also the IOP can be low because of the ciliary shutdown which is taking place, and also the ciliary, considering the choroidal and ciliary body detachment which can take place because of the cyclic membrane which can be present over the ciliary body.
Okay,
and also they can be associated retinal detachment or choroidal detachment, which can also account for this low IOP.
Okay, just one more question. How did you assess the cells and flare in the anterior chamber? You said 1+ cells.
Cells and flare, we have to put a 1:1, 1+1 1:1 mm of slit, and slit has to be put, and it the illumination arm and the viewing arm has to be at 45 degrees, and the magnification has to be high, that is 25 times magnified, and we have to focus the beam at the anterior chamber, and the cells can be seen moving in the anterior chamber because of the aqueous convection current, and seen as fine particles, and the flare it is seen normally the aqueous is clear, and when we pass this slit lamp beam, it cannot be seen in the anterior aqueous humor, but once these proteinaceous exudates are present, the slit lamp beam can be visualized clearly because of the Tyndall effect, that is recognized as flare. It is graded according to Sun's classification, that is standardized uveitis nomenclature, as cells are classified into 0, 1+, 2+, 3+. 0 is that is no cells are present. 1+, around 0 to 5 cells. 2+, 6 to 15. 3+, 15, 16 to 25. 4+, 25 to 50 and more than 50. Then flare is also classified according to Sun's classification into 0, that is no flare, 1+ faint, 2+, that is the lens and the iris details can be seen clearly, and the lens and iris details becomes hazy in 3+, and the 4+ is fibrinous exudates in the anterior chamber.
So to sum up, you have a history which is insidious without much pain. And now we come to examination. It shows you something similar to a chronic uveitis. We are not sure, but the vision is definitely out of proportion to what you have found. So shall we move on to the investigations?
One or two things, Faiza. One is when you say posterior synechia, what kind of posterior synechia this patient had?
This patient had posterior, the pupil, the 360 degree of the pupil was adherent to the anterior capsule of the lens.
Can you come to the picture?
Suggestive of, yes.
Okay. Were they fine synechia or the filiform synechia, or they were broad-based synechia?
Broad-based synechia.
Okay, so that is one thing I wanted to highlight. Just looking at the picture, it looks like it's a broad-based synechia, which are again typical of granulomatous uveitis. So you have findings which are, little in contrast to each other, while KPs are non-granulomatous. The synechia are more of granulomatous varieties. That is something, again, clinical picture can be mixed. So one should not get stuck in that. Second, why do you think the patient had 360-degree synechia and did not develop iris Bombay? I think you answered that already, because
he's having a low IOP.
The patient had low IOP. So we will come to that, why this patient had low IOP. You just enumerated the causes of low IOP. So any guesses as to why this patient had low IOP? You have listed several causes, but why this patient is likely to have low IOP?
It could be a ciliary body shutdown, or it could be any associated retinal detachment or choroidal detachment posteriorly which is present.
Okay, so that is something very important. Just looking at the anterior segment, one would think that ciliary body shutdown has happened. So remember, when you have 360-degree posterior synechia and the iris Bombay do not develop, that's a relatively bad prognostic sign, because that shows that ciliary body is going to has already shut down. So that is the patient who is going into permanent hypotony. It's not a good sign, good prognostic sign. Second thing is, it is possible that patient does not have 360-degree synechia. It looks like 360-degree synechia, but there are few open spaces between the iris and the lens, which is allowing aqueous to pass through, and that technically will not become seclusive pupil. Okay, so that is a subtle difference you have to make out clinically. It is important because if just few empty spaces are open, few synechia are missing, then it is not a bad sign with hypotony. Okay, but if you have seclusio pupillae along with hypotony, that's a relatively poor prognostic sign. Second thing, we saw the anterior segment of this patient. Now, when would you suspect a posterior uveitis in a patient with anterior uveitis? For example, just going by the clinical picture, all signs of anterior uveitis, chronic anterior uveitis. You look at the fundus, you can't make out much, but whatever is seen is normal. Now, what are the clinical signs in such patient which will tell you, no, definitely this patient has some posterior activity or posterior involvement?
If his vision is not in accordance with only the anterior uveitis, a very low vision, then it can suggest a posterior segment involvement, posterior uveitis associated with anterior uveitis. Then if the IOP is low, intraocular pressure is very low, then also we have to suggest, we can also consider posterior segment involvement.
And third would be the relative afferent pupillary defect, of course, if there are no posterior synechia. So just going by this patient, if you have vision of a chronic anterior uveitis, vision which is very bad, and if you look at the posterior segment, by and large it looks normal. Even then, when the vision is so bad, you have to go further in your investigation and rule out any posterior involvement thoroughly. The same vision, same patient had 6/9, 6/12 vision with you can say probably normal posterior segment on fundus examination. Then I would not go with ultrasound, but the patient with finger counting vision and the similar findings, I will go ahead with the posterior further evaluation of the posterior segment. So that is something which is again a very important clinical markers. Tell you when to go ahead with further investigations in a particular patient and when not to go ahead with further investigations.
Yes, in a patient in whom you are able to see the retina, you took a photograph of the retina, which means the media clarity is about 6 by 60, 6 by 36. But the patient's vision is only 1 by 60. So there may be a little bit of vitreous haze, but the vitreous haze will also come up in the the retinal picture that you are taking. So despite that, despite possibility of 6 by 60, 6 by 36, since you have got 1 by 60, you should be very much suspicious of bilateral optic nerve involvement also. Bilateral optic nerve involvement in a uveitis. Okay, that is also a possibility. But the pressures are low. The pressures are low, and with low pressures. So if the pressures were to be high, that would have been again another reason why there could be a decrease of vision. Okay, high pressures, functional optic nerve damage, something like that. But here pressures are low. So one more thing I want to add: exudative retinal detachment, which is sometimes occurring in panuveitis or posterior uveitis, generally does not cause low intraocular pressure. It is the rhegmatogenous retinal detachment which usually causes the low intraocular pressure. Am I right, Vinod?
Definitely. But again, depends on the involvement of the ciliary body.
Yes.
I think this particular patient had involvement of the ciliary body. Yeah. Probably that's why this patient had low IOP, which improved significantly after the initial treatment. One, again, very small point, Faiza, it's being more critical. It's because you said the iris pattern was lost in your examination. But in these two photographs, it looks pretty much maintained, So that is something which, again, you are presenting the patient. You have to be a little more careful when you, say something about the finding.
Sure. Should we move on? Sudha madam, any further questions from your side?
Let's move on. As for the iris pattern, actually, that is only seen by slit lamp. It looked something blunted. In the picture, it is not that obvious.
Yes.
Okay. So move on, Faiza.
Before that, let me ask Dr. Faiza or some of the other people, Amrita, or whom should I ask, madam? Who is the other final year along with Faiza?
Lakshmi, can you be ready?
Okay. Lakshmi, can you tell me what are the causes of bilateral chronic uveitis? Let's look at the differential diagnosis of bilateral, simultaneous or maybe sequential uveitis, right?
Yeah.
That is what will come to the
I think we'll make it easier. We can add either acute or chronic. So then it will become easier. Yeah.
Who is it? Lakshmi. Yeah.
Lakshmi or Srija. Somebody please answer.
Causes may be due to tuberculosis.
No, I think you should on your video and answer. Thank you.
Causes may be due to tuberculosis.
Okay, so infective variety, TB and?
Hello.
Hello.
Yeah, we are hearing you, Lakshmi.
Tuberculosis or sarcoidosis, maybe systemic involvement. Then non-infectious variety, maybe weak age.
Okay.
Lakshmi was actually not well. She's suffering from fever, and you are right.
Yeah, it looks like.
I think Srija can answer.
Okay, they are all not answering. So I think we come back to, they have all ditched you, Faiza. They all ditched you, your batchmates. Completely ditched you. You are in the hot seat, they don't want to come in. Okay, you can tell.
Bilateral uveitis, we have to first.
Hello?
Yes, Rija, we can hear you. Can you be a little loud?
Hello. Hello, sir. Am I audible, sir? Hello?
Yes, Shirja.
Hello. Granulomatous uveitis. Hello. TB, syphilis, sarcoidosis. Hello.
We can
yes.
hear you, Sirija. We can hear you.
Yes, sir. Tuberculosis, syphilis, sarcoidosis, then leprosy, then viral infections like herpes simplex, herpes zoster.
So herpes zoster is typically, unilateral. So again, we'll make the question little more specific. Tell us the causes of bilateral granulomatous panuveitis. Maybe now this appears more specific question.
Leakage causes bilateral granulomatous panuveitis.
Okay, one is leakage.
Sympathetic ophthalmia.
Okay, lovely. 2.
Tuberculosis can be bilateral panuveitis.
Okay, 3.
Then sarcoidosis.
Okay, very important. Must be always ruled out.
Behçet's.
Behçet's. Yes, sir. Behçet's.
Behçet's typically would lead to a non-granulomatous, but can lead to granulomatous also. Rarely. And then a very important cause is lens-induced uveitis. Lens-induced uveitis, most of them tend to occur, tend to be granulomatous, and in certain cases they are bilateral as well.
Okay.
And of course, the DD would be different if we come to bilateral anterior uveitis, because typically leprosy would be causing anterior uveitis and almost never leads to posterior uveitis. So I think this is something which is a never-ending process. We can keep on, but in the almost all uveitis textbooks, there is separate category tables made, whether it's bilateral anterior, unilateral anterior, bilateral posterior, and unilateral posterior. So that is something, if you remember those tables, it is really useful to have those tables ready, in your armamentarium. Always very useful from postgraduate.
This is the process of naming and meshing. Faiza, can you just explain that process, which the Sun classification has told us about, naming and meshing?
For naming, we have to anatomically classify the uveitis, that is into anterior, posterior, anterior, intermediate, posterior, or pan-uveitis. Then we have to pathologically classify it into granulomatous and non-granulomatous. Then into acute and chronic. Then we can get certain BDs for the etiological part, and according to that is the naming, and then we have to find out according to the naming part. We have to find out which is the most probable etiology which can happen according to the anatomical and the pathological involvement of the eye. And according to that, we have to tailor our investigations for each individual. We should not be doing all the investigations for all the patients. According to the clinical findings and the history, we have to tailor the investigations according to. This is known as naming and measurement.
You're mute, sir.
I think, Faiza, we go ahead with further investigations and then let's see what comes out.
Yes, sir. So a B scan for this patient was done, and he was found to have a choroidal detachment with an exudative retinal detachment inferiorly in both the eyes. Choroidal thickness was increased, and he had no T sign. An OCT was done, the right eye. This was the initial OCT which was done, and it was because of the vitritis, it was not much clear. It is showing a normal vitreoretinal interface with subretinal fluid which is present, and some RT irregularities were also present. And these are the other OCT pictures which I've taken on the following days once the patient was admitted here, showing ILM folds and a diffuse subretinal fluid with increased choroidal thickness. And the second picture of this OCT is showing some fibrinous exudates in the subretinally. The other OCT pictures which I've taken on the following days. OCT of left eye. This is also the initial picture, which was showing an altered foveal contour with cystoid edema, with the focal subretinal fluid which is present with irregularities in the RT, and this was taken on the following day, showing a minimal subretinal fluid, and these are some fibrinous exudates subretinally, and he had an increased choroidal thickness of about 368 micrometer in enhanced depth imaging. That's it about the investigations concept.
These images are at presentation, or these are
Yes,
on follow-up?
Presentation.
Okay. Okay, so once you see the ultrasound of this particular patient, can you please go to ultrasound? Okay, so please describe the findings if you would for me.
Yes, sir. He's having a mild vitritis with inferior choroidal detachment with an exudative retinal detachment, and there is increased choroidal thickness, which is seen, and there is no widening of the subtenon space. That is the D sign is absent.
How much is the choroid thickened? What is the usual thickness and how much it is thickened here?
Sir, the calipers calipers are not shown here. It was about 2 millimeters, sir. Normal choroidal thickness is about 1.2, 1.1 to 1.2.
Okay, more than 1.2, 1.2 maybe considered.
Yes.
Significant thickening, is it?
Yes.
So, and what was the extent of choroidal detachment?
It was detached inferiorly, sir. Inferior.
No, this membranous echo that you are seeing in the ultrasound, is it a choroidal detachment or a retinal detachment?
This is a choroidal detachment, since it is not attached to the optic nerve.
We know.
See, the choroidal detachment would be seen in the periphery. You know, of course, you will not see the same attachment to the optic disc in the same scan. Okay, so that is one thing. So there are other measures by which you can differentiate a choroidal detachment from a retinal detachment. So typically, they would say that choroidal detachment is limited posteriorly by the vortex vein. So you wouldn't see the choroidal detachment going posteriorly, while usually retinal detachment would extend posteriorly, and choroidal detachment, you will see the bi-peaked, you know, it will have two peaks, which at times may be difficult to distinguish, but retinal detachment would have a single high peak. Retina is more mobile, while choroidal detachments would not be that mobile. So these are the various features by you can distinguish, and it becomes a little more complex when both are present. So this is unfortunately not a very good scan to show when you have a CD or a RD both in a particular patient. Either you can add two scans showing both of them more prominently. Okay, so that is one thing. In fact, I would like to know, by ultrasound, was there any posterior detachment also, either retinal detachment or choroidal detachment?
Posterior detachment, sir?
Retinal detachment, was it extending to the posterior pole as well?
No, sir. No.
Actually, here in the center, you have centered this on the optic nerve, right?
Yes, sir.
Which means the cleavage of the retinal detachment from the retinal pigment epithelium has reached very close to the optic nerve, right? Has it reached?
Yes, sir.
Yeah, and it's an inferior detachment.
Yes, sir.
So it's the inferior detachment is reaching very close to the optic nerve, in fact.
Yes, sir.
Very close to the macula, and actually that is overshadowing the optic nerve when the patient is sitting up. In the vitreous, you can see that membranous echo is actually on top of the optic nerve. But this is not seen in the clinical picture that you have. So is it in the same day that you have done this, or maybe this is done after maybe a couple of days?
No, it was done on the following day he was admitted. He was seen, and the following day, the same day itself, sir, without starting any treatment. We had admitted the patient, taken a B scan.
No, admitted the patient and taken the B scan, but when was the picture taken? Retinal picture taken? Is it the same day?
Fundus photograph.
Yeah, fundus photograph.
Oh, fundus photograph. Initially we tried, so it was not much clear. So the disc could not be seen in the fundus photography. It was very hazy. So 2-3 days later, we took this B scan was done initially.
Okay, B scan was initial, and after treatment we have
photograph.
taken the fundus.
Yeah,
photograph.
fundus photograph was taken later.
After
B
the
scan
treatment.
was, yes, yes. Yeah, late. First B scan was.
Okay, at this point of time, you could not get the fundus photograph, which is very correct, because maybe through the detachment you could not see actually. This was a very bullous detachment probably at that point of time.
So if
Vinod,
we just,
sir, do you think this is an retinal detachment, because it doesn't show a high spike there? Would this be a choroidal detachment?
No, this looks like a retinal detachment.
It's not. I mean, it's not adherent to the optic nerve. It's on this side. I don't know this picture. That's
Madam,
called
only
we
if
got
it is a total retinal detachment will it be adherent to the optic nerve. If it is an inferior exudative detachment, it may come near the optic nerve, but it may not reach the optic nerve. So now, why did you say that this is an exudative detachment? Did you make the patient lie down? Was this patient, was this ultrasound taken when the patient was sitting up, or was the patient lying down?
Sitting position.
Yeah, in the sitting position. So if the patient were to be lying down, probably what Madam said would have come into play, because then it would have, because if it was an exudative detachment, it would have spread throughout the retina, and then probably you could have seen that it just touches onto the optic nerve. So because this, so but why did you make the diagnosis of an exudative detachment? This could have been a rhegmatogenous as well. You don't see the rhegma. Why did you make the diagnosis of exudative detachment? Did you actually look for shifting fluid when the patient was in different positions?
No, his B scan was taken only in the sitting position.
No, see, if you have to say exudative detachment, either you should say that, patients with multiple positions, there was shifting fluid, and that is why I'm telling exudative detachment. Yes, I agree that in uveitis, mostly you will get exudative detachment only. Okay, but for you to say that out in the exam, you should have shifting positions. Vinod, anything more?
any other signs of exudative RD on retinal on ultrasound? Any other signs on ultrasound which indicate that this may be an exudative retinal detachment?
Yeah, signs of vitritis, sir, and increased choroidal thickness.
Okay, they are okay, but another feature is many echoes in the subretinal space. If you see, that would point towards the diagnosis of exudative retinal detachment. And another very important point to look for in these particular patients is to look for focal areas of choroidal thickening in terms of choroidal mass, if any. So that is a very important clue again towards the final diagnosis. So it's very important to look for any focal choroidal thickening in such patients.
And anyway, there's generalized choroidal thickening here anyway.
And go to OCT. Now, I hope this is at presentation, isn't it?
Yeah, yes, yes.
So again, the qualities, of course, it's bound to be bad because media was hazy. But one pointer is if you have swept source OCT, that will give you much clearer pictures because it can travel through hazy media. So that is one advantage of clear advantage of swept source OCT over conventional swept spectral domain OCT. And second, again, this picture will give you a very important clue towards the diagnosis. So can you enumerate the findings here?
Yes, sir. The vitreoretinal interface looks normal. The foveal contour is altered. There is subretinal fluid which is present, subfoveally, and there is irregularities on the artery and increased choroidal thickness.
Okay, so I'll take your word for it for now, but if you see, it is really very difficult to comment on the choroidal thickness in this particular scan. All you can say is outer choroid is not visible. So to say the choroid is very thick, it's very difficult to say. Second is look for the wavy choroid. If you see, the RP line is not straight, it is kind of wavy, and of course there is subretinal fluid, which is not again very typical of inflammatory pathologies in this particular scan. So in VKH, they say that typically there are multiple septate fluid pockets, and
Yes.
there may be bacillary layer detachments, which are usually very well seen. Again, because of the media haze probably and very limited scan, we are seeing this kind of picture. But the wavy choroid which is there gives you an idea that we are dealing with the patient who has a diffusely thickened choroid.
This is of the same eye, right?
Yeah, and of course, if the scans are clear, it will give you a clue about the vitritis also if you see carefully. So vitreous cells will be visible on various OCT scans. Again, difficult to comment because noise is too much in this particular patient. I believe these scans are after the treatment, isn't it? Initial treatment.
No, this is not after the treatment. After the treatment, scan is coming in the later slides.
Okay, because in these scans, the RP layer is totally straight, so they do not go hand in hand with the previous picture.
Yeah.
Days post, I think. Yes, 1 or 2 days after.
Yeah, 1 or 2 days after, madam.
No, because there's a huge exudative detachment in the ultrasound, and that much of exudative detachment, if it is there, probably it is there in both eyes. Then you are looking at some diagnosis like a VKH or something like that with this picture. And the RP being entirely straight is a little untreated with exudative RP. It's a little unlikely, is what Vinod is trying to say.
Patient has taken some treatment from outside. The records are not available actually. We don't know what he has taken from.
Okay, that's again a very important confounder which will come. So it is important to decipher from the patient that what treatment the patient is on. Once the patient is on steroids, in any form, this is going to change your clinical picture significantly, and you will have to interpret all the findings in light of therapy as well. Again, if you see the choroid, the OCT on left eye, the left picture, it's not very typical of VKH. If you see, there are large choroidal spaces, choroidal vessels, which are visible not too far away from the RP. Now, that is something which is not seen in acute phases of VKH. In VKH, you will have a diffusely thickened choroid, and most of the times you will not be able to see any large choroidal vessels in such patient. Choriocapillaris and middle layer is so thickened, that is so diffusely thickened that you will not be able to see the large choroidal vessels as you are able to see in the top left scan, So that is again something which is little atypical for VKH in this particular patient.
Actually, we did have a differential diagnosis of this patient on steroids and developing CSR. But I don't know. Ultimately, he did improve with intravitreal steroids, IV steroids.
No, ma'am, but there is a significant uveitis component, no, with the
Uveitis is there, of course. He's on treatment for uveitis.
So if it is uveitis plus CSR, it becomes a little
Very complicated issue.
At least not as an exam diagnosis.
Yes.
Absolutely no. You have to either commit towards uveitis or towards CSR, not in exam. In reality, maybe yes. But yeah.
Faiza, just because this topic emerged, have you heard about Occam's razor and Hickham's dictum? Anybody else? Any other postgraduate? PG? Okay, so Occam's razor is something they say that, you always try to fit in all your clinical findings into one diagnosis. And it is not, good to make diagnosis of two disease entities in a particular patient. So that is what is Occam suggests. But Hickam said, no, it is not true. You might fit as many diagnoses as you please in a particular patient, So that is what is the clinical scenario. So by and large, we'll try to fit in one diagnosis, for example, VKH, and try to put in everything in inflammation. But sometimes, as ma'am said, you may have another diagnosis as well. So clinically, as a clinician, you must always keep your mind open to both these entities. Okay, go on.
So in an examination, you should follow the Occam's razor principle. In reality, you may have the dictum of whose dictum?
Hickham's dictum. If you have a Hickham's dictum, it becomes a case report,
Yeah.
Most of the time. Okay, Faiza.
Moving on to summary. He's a 44-year-old male with no non-comorbidities, presented with a history of fall of white cement to his left eye 2 months ago. And at this event, he had noticed defective vision of his left eye. And 2 weeks later, he had noticed an insidious onset of painless defective vision of his right eye. He gives history of trauma to his left eye 2 years back. On examination, general examination, vitals were stable. Systemic examination were within normal limits. Ocular examination, the best corrected visual acuity of both the eyes were 1 meter counting finger, with a normal head posture, autophoria, and ocular movements full in both the eyes. Anterior segment examination in both eyes showed mild circumcorneal condition with a few pigmented keratic presbyteries over the corneal endothelium, and anterior chamber depth was regular in depth, with the peripheral anterior chamber is equal to half corneal thickness corresponding to Masquerade grade 3 with the 1+ cells and flare. He had seclusion pupilla in both the eyes with non-reactive direct and concentric reflexes of the pupil. Lens had a posterior subcapsular cataract in both the eyes with pigments on the anterior lens capsule. Fundus examination of both the eyes, the medium was very hazy due to reticular opacity and probably uveitis, and disc and vessels were visualized. Disc margins were well defined, and this size was normal in size and shape. The cup disc ratio was 0.3, neuroretinal rim was thin. There was no evidence of any disc edema, and macular details could not be made out. Even the peripheral fundus details could not be made out. Applanation tonometry showed a value of 4 millimeters of mercury in both the eyes, with the corneas complete, showing grade 3 open angles superiorly, nasally, and temporarily in grade 4 open angles inferiorly with a hyperpigmented papillae measure. The scan of both eyes showed choroidal detachment with exudative retinal detachment, and my diagnosis would be bilateral panuveitis with complicated cataract.
Okay, would you want to add something to this diagnosis, something which is very crucial?
Sir, the etiology?
We'll come to that. Clinical diagnosis, bilateral panuveitis is something unusual in this panuveitis.
Chronic.
What is special about this panuveitis which you picked up on the ultrasound?
It has both choroidal and retinal detachment.
Okay, so that is very, very important. I think If you go back, all of your diagnosis, history and examination, that is the single most important factor on which you based your diagnosis, the final diagnosis, isn't it? So it's very important to include that in your clinical diagnosis. I would write bilateral panuveitis with exudative and choroidal detachment. That is more important than complicated cataract infect in this particular patient.
You know why Vinod is telling that? Faisal, just think. Is it bilateral intermediate uveitis?
No, sir. It
No.
is.
Why?
Because now.
No exudative detachment, right? In intermediate uveitis, you cannot have exudative
detachment.
Right? It's a bilateral condition. It cannot have that. Is it bilateral toxoplasmosis? No, because exudative detachment is here. Okay. Is it? Is it bilateral AR? It will also have bilateral uveitis, bilateral vitritis. No, because exudative detachment is here. It will be seen in a very late stage. Sometimes there will be a retinal detachment, but not like this. Okay. So you can exclude a lot of other panuveitis based on your exudative detachment. That is why that is a very, very important thing. Panuveitis with exudative detachment is different from panuveitis alone. Okay, that is why he made that statement.
So now, based on your clinical diagnosis, what would be your differential diagnosis?
First of all, I would consider bilateral panuveitis with exudative retinal detachment. First diagnosis would be Masquerade syndrome. And considering
patient had history of trauma, if I remember it correctly.
Yes, sir. 2 years back, but no. He gives a history of just redness which had resolved on topical drops, and no other history about that event is available. No other details. He's telling that history. There was no evidence of. There was no history of any photophobia or defective vision following the trauma. Just he had some redness.
And the patient had another episode of fall of cement in the.
That is recently, 2 months back. That is when he had noticed his defective vision.
Okay, so we have the DD of sympathetic, we have DD of VKH. You might want to put either of them first. But of course, these were non-significant, non-open globe injuries. They're closed globe injuries. So we would. And one very important thing is, again, mentioning that there's no history of intraocular surgery, previous intraocular surgery in such a patient. Okay, any other differential?
We have to consider differential diagnosis, which includes infectious etiologies like tuberculosis, syphilis, considering the panuveitis, and also we have to consider non-infectious etiologies like sarcoidosis, Behçet's disease, and sympathetic ophthalmitis. Since there is no history of intraocular trauma or surgery, then.
I think, why would you consider the diagnosis of Behçet's or sarcoidosis? They typically do not present with, exudative retinal detachment and peripheral choroidal detachment. So that is why we want to keep the specific entity of exudative RD and CD in the clinical diagnosis, because that changes a lot. Okay, your differential is going to be based on that. Okay, so tuberculosis maybe yes, granulomas if present large can lead to exudative RD. Again, sarcoidosis rarely you may have, but Behçet's etc. typically do not lead to this kind of picture. Even syphilis does not lead to this kind of picture. So as such, they are quite not so common, especially in our scenario. Any other thing?
Masquerading syndrome.
Okay, very important is Masquerade Syndrome to keep in such a patient. So that is why I asked for any focal choroidal thickening. Okay, so it is very important to rule out Masquerade. But again, Masquerades would not have that amount of anterior uveitis. Any other differential? Suppose the patient was a hypermetrop. High hypermetrop.
Uveal effusion syndrome.
Okay, very important is uveal effusion syndrome. But again, those patients tend to lack any intraocular inflammation. Something again which presents with posterior uveitis or posterior detachments.
Posterior uveitis, but patient will have evidence, have complaints of pain.
Okay, but you have to list them in your differential. Okay, so these are the closest differentials we have in this particular patient. If we talk in terms of exudative retinal detachment, of course, at the top being VKH and sympathetic, if you want to put it, but these are the must haves in your differential. And then you can say why you have excluded these differentials based on all the major features we have just discussed.
Yeah, so can you tell us some features in this particular case that will support the diagnosis of a VKH and that would not be supportive of a diagnosis of VKH? Both are there in this case. Can you tell me? What are the things which supports?
Point in favor of VKH, the patient has an insidious onset of defective vision. And on examination, the patient has a bilateral, very reduced vision, that is 1 meter counting finger. On evaluation of anterior segment, the patient has mild anterior uveitis. But he has got a broad-based posterior synechiae suggestive of granulomatous uveitis.
What type of uveitis does VKH usually produce? Would it be granulomatous or non-granulomatous?
Granulomatous and uveitis.
That goes against your picture, right?
Yes, but the
you had a non-granulomatous sort of picture.
Posterior synechiae, since it is broad-based, it suggests granulomatous.
Maybe he was on a lot of topical steroids, maybe 2-hourly topical steroids somebody would have started. And so the anterior segment signs may have reduced a bit. Is it possible?
Yes, sir.
Or the patient was already on systemic steroids when the patient came to you? You don't have the treatment history.
We don't have the treatment history, but he is telling he has not taken any treatment. We don't have the treatment history. He has no records of it.
Any other feature against being a VKH?
If we point in favor, he has bilateral exudative RD. Point against VKH is
yes, a non-granulomatous uveitis. That's against.
Yes. Then, since it is a chronic picture, his fundus, they cannot be seen, but he's not having any sunset glow fundus.
But that occurs very common.
Yes. Then he has no other systemic associations like or neurological manifestations like neck stiffness or.
He does not have headache as well.
No history, and he as well as does not have any tinnitus or hearing deficit, and he does not have any integumentary findings also or skin findings, which comes actually later.
And I think another important feature, which is, of course, usually VKH patients do present with posterior uveitis, early in the course of disease because of vision is affected. Now, why this patient did not ever present with posterior uveitis, that is something little atypical in this patient. And second atypical feature is again, sequential nature. Typically VKH is bilateral, but of course it can be sequential in certain cases. And in fact, we only had reported a case where one eye had involvement in terms of VKH and the second eye got involved 2 to 3 years later even. Okay, so that is something which can happen in VKH. So there are several atypical features in this particular patient, including non-granulomatous kind of anterior segment picture, such as severe anterior uveitis, patient presenting so late with anterior uveitis and never presented with features of posterior uveitis. And last but not the least is peripheral choroidal detachment. Again, it has been reported can occur in VKH, but little less common than exudative RD. And of course, I think you gave pulse steroids to this particular patient.
Yes. We had initially admitted the patient. He was investigated for all the infective etiologies, and the routine investigations were done. His Manto test was negative. A chest X-ray was done. It was also found to be normal. Then his BDR test was done. It was found to be normal. His ESR was 18, and his blood sugars were normal. We had done it before giving steroids. Then total count, everything was normal. He had no other site of infections in the body, and we had given him we had given him IV methylprednisolone, 500 milligram BD for a dose of 6 doses, 3 days pulse dose, and gradually we had taken him over oral steroids at 1 milligram per kilogram per day, and now presently he's on oral corticosteroids. Sir, I have the picture of his OCT and B scan being done after his IVMP and was completed, and some few days later.
Yeah. Meanwhile, you put your slides. I think one important investigation in VKH is fluorescein angiography, if you are able to do. So that will give you a very important clue towards the clinical diagnosis, because it will show you those pinpoint leaks. It will show you pigment clumps. It will rule out any CNVM if they are in the patient. So, and it will also very importantly tell you the status of the optic nerve if it is involved. If optic nerve is involved in patients with VKH, it is known that the final prognosis is relatively poor. So it's very important to do FA. If you are not able to do at a first presentation, always if the patient clears up 2 or 3 days later when people dilates a bit, you can go ahead and do a fluorescein angiogram.
Yes.
And of course, ICG if you have.
This is the inferior retina being shown?
Yes, sure. Yes, sir.
Okay. So post IVMP, this is attached, which gives us a reasonable diagnostic clue that this is therapeutic clue that it is VKH itself.
Yes, and this was his OCT of right eye. The subretinal fluid had diminished, was reduced, and the A500 exudates also had reduced. OCT of left eye, similar picture.
So possible they have only eye findings in VKH without any neurological and ear findings?
According to the revised criteria for VKH, it can be divided into complete VKH, incomplete, and probable VKH. And the third category, that is probable VKH, can have only the ocular manifestations without the systemic manifestations.
When should you start? Should you start immunosuppressants to start with the VKH? Or you will just start with steroids only?
We can start with immunosuppressants once we have found a sudden explosive event with the sight-threatening event. That is, once the patient is intolerable to corticosteroids, that's also another indication for starting immunosuppressants. And if the patient is, since it is a VKH, we have to slowly taper this corticosteroid dose over about 6 to 12 months. So if the patient has to be on corticosteroids at a dose of about 10 milligram for more than 3 months, then we can consider the patient to start the immunosuppressant drugs.
Generally, FISA in VKH, you will require very long treatment, and it is a good idea to start immunosuppressant right from the word go, because your 10 milligram for 3 months and all will definitely be there. It will be a long drawn treatment. So it's better to start the patient on immunosuppressants. Okay. Because you should somehow limit the steroids as low as possible. Okay.
Okay. 2 things, Faiza, again. One, the kind of chronic picture he had, and the fluid, all the fluid, you know, just how it vanished in 2-3 days. It was something again. It will go away little slowly, but it just vanished. So that was wonderful. And second is, you know, you always tell these patients that you are going to require these steroids for long periods of time in the beginning itself. What happens is these patients take therapy and then they think they are all right and they stop. And it is known in VKH that once the recurrences start happening, they become more and more steroid resistant, and then you definitely have to shift to immunosuppressive. So it is very, very important to impress on the patient in the beginning itself that he must not discontinue the therapy in between and must continue the therapy for long. And of course, nowadays people say that choroidal thickness is a very important marker for early recurrence in these patients. Earlier it was said that do a OCT, and if the SRF comes, it is an indication of recurrence happening in these patients. But nowadays they say that the choroidal thickness starts increasing even before the SRF comes. So if you do a serial OCT, then it can give you a clue as to if the patient is going to have recurrence soon or not. And of course, in any case of where patient is non-tolerant to steroids or any steroid-related complication, then we have to shift to immunosuppressives. And do watch out for super added complications like CNVMs, which are very common in these patients and can limit the final visual outcome.
So I think that probably we are looking at multiple reasons of the 1/60 vision. One is a part of anterior, partly cataract, the posterior subcapsular cataract you mentioned, partly vitritis, partly exudative detachment. And if you've done a fluorescent, probably I think that the discs may have leaked through. But even though I think that the VKH discs look a little more edematous and hyperemic, your picture was not suggestive of that much hyperemia. It is a little hyperemic, but not so much. So that could be the reason for 1/60 vision. And after pulse steroids, if your exudative detachment settled, how much did the vision improve? Did it improve to 6/60?
Yes.
How much?
Now patient is having 6/60 vision in both the sides. His IOP has increased to 12 millimeters of mercury in both the eyes. And his exudative retinal detachment, since again his pupil is not dilating at all, we have to do a repeat B scan, and it was found that his retinal detachment has it has decreased and the retina has opposed. And his OCT also, it is much clearer, and the subretinal fluid has decreased as well as in both the eyes.
Many times you will not have a hearing defect. You should send for an audiogram and specifically look for some frequency loss, maybe higher frequency loss.
Higher frequency loss. His ENT consultation was done here, but his pure-tone audiometry also was done, but he was not found to have any hearing deficit. As well as dermatology consultation was also done. There was no evidence of any manifestations of leakage at present.
One more final thing I want to say that pulse steroids is a huge, significant weapon in our hands, which should be used very judiciously. And before you use pulse methylprednisolone or pulse dexamethasone, make sure that the patient does not have any infection. If you have an infection and if you give pulse steroids, it's done. And the infection may spread and he may develop some brain issues, etc., etc. The infection may spread to multiple places. Yeah,
I think that's good, sir.
Sudha madam, any closing? What are the learnings for all of us from this? This is an excellent case being presented. Congratulations, Faisa. It is very well presented.
I do think that we had a good, very fruitful discussion. And even though maybe the diagnosis is not the key point, actually, the PG should be able to work it up in a systematic manner. And I think Faisa has done a good job for that. She's been able to tell. So these are cases which come as a life normally. I mean, it is not theoretically, everything is not perfect. So it comes like this, but you should be able to approach the patient in a systematic manner and find out, like as she said, as vision is low, out of proportion, she should be able to go further. So we do have the investigative modalities now compared to previous years. So now we can use those, but we should know when to use them judiciously. And I think the discussion has been very wonderful. Thank you, Dr. Gopal and Dr. Vinod, for a very good learning points from this.
Thank you, Faiza. It was I think you did a wonderful job. You held the fort alone, and when your all your co-PGs, they ditched you. So anyway, you did a very good job. And thank you
Thank
for
you so
handling
much,
that
sir.
call.
Thank you,
Thank
sir.
you very much.
Gopal, sir.
Yeah, thank you very much, Sudha Madam and Mallika Madam, and all the postgraduates. And special thanks to Vinod. So we'll be back next week, 15th of